Thank you, Dr. Govil, for giving me this opportunity. Good afternoon, students. I hope you are enjoying the academics and learning a lot about the critical care. So, I'll be talking to you about the acute confusion state in the ICU and also delirium basically in the ICU. I'll just show you this video. Not running. No loading or? Okay, no problem. This 65-year-old lady came to us in the ICU as a suspected of lung infection. After 24 hours of treatment, and she started running from the bed. As you can see, she taking out all the monitoring lines, removing the pulse oximeter probe from the hand, and she just not listening to the nursing staff and arguing, why don't you let me go? Why are you keeping me over here? So, what do you think? What has gone wrong with her? She came with a lung infection, and why is she behaving like this after 24 hours of admission to the ICU? So, she got no brain problem or no pre-existing brain problem. So, why is she behaving like this? Pardon? Yes. Do not call the word ICU delirium. It is, but it's a delirium definitely. So this is a common thing to happen in the ICU patients, and in fact any kind of critical illness or serious illness can push the patient to delirium, state of delirium. So delirium or it's acute confusion state is sort of, I will say, it's acute brain failure which can happen to any patient who come with a critical illness. Any patient admitted to the ICU, obviously we have to have acute illness or critical illness of any organ. Commonly patient come to the ICU with hypoxia, hypovolemia, hypotension, acidosis, or any organ failure like kidney failure, liver failure features. So these all are critical illness and they can push the patient into the acute brain failure transiently and what we call ICU delirium or acute confusional state. In the human body, all the organs are sort of interdependent on functioning, proper functioning of each other. There's some certain kind of homeostasis which is maintained in the body. Like in the previous class only, Dr. Anand were talking about the hepatorenal syndrome or HRS. What can happen in a patient of liver failure? They do develop kidney failure, what we call HRS. Same way, patient of cardiac failure can develop renal dysfunction and vice versa, what we call cardiorenal syndrome. This guy varies 1, 2, 3, 4. So one organ major dysfunction can affect the functioning of the other organ. Same thing can happen in an ICU patient coming with one specific illness issue can affect the brain function and but leading to the acute confusion state or delirium in the ICU. This is what was happening to the patient, what you saw. So the definition given of delirium or acute confusion state as per the DSM-5. DSM is basically Diagnostic Statistical Manual of Mental Disorder, and they define almost all the mental illness as the gold standard for all the mental illnesses. But we as an intensivist are not used to the DSM, which is basically written and defined by the psychiatrist, this DSM manual. DSM-5, the latest modification of the guidelines came in 2018 and last modified by in 2022. Before that, there were definitions given DSM-4. So they talk about the acute confusion state having patient have disturbance of consciousness, the disturbance in attention, disturbance in cognition, and all these disturbances are not better explained by another pre-existing, evolving or established neurocognitive disorder. The patient do not have before coming to the ICU any kind of brain issue or any kind of neurological problem. Patient may have some other underlying medical condition, and all this acute confusion state develop over a short period of time, within few hours to few days. as you said, that patient develop delirium within 24 hours, or they may have very fluctuating course. Morning, patient looking fine. Evening, they may start behaving wonky, and next day morning, when you come for the round, the nursing staff commonly will tell you, so the last night, so and so patient was behaving very abnormally, trying to run away from the bed, trying to pull out all the lines, all the antidotal tube, the patient on ventilator, and removing the monitoring lines, all these things. So the course of illness also fluctuate depending on the day of the time. So this is a neuropsychiatric manifestation system disturbance, as I said. And according to psychomotor behavior, the delirium can be classified into hypoactive delirium, that is a little less motor activity, or hyperactive delirium, like what we saw classically, that video could not play, is a hyperactive delirium. Patient is more agitated, more aggressive, and there is mixed variety. Sometimes patient is little hypoactive, other time you find patient become hyperactive. So this is called mixed variety. But commonly what comes to the notice, hyperactive variety. When the patient is agitated, fighting, running away, that is called hyperactive variety. Hypoactive patient may be lying very quietly in the bed, just looking at you, not listening, not paying much attention. That is called hypoactive variety. So again, just to summarize the various points you come across in a patient of delirium is that is disorganized thinking, even thought process is disorganized. Fluctuating mental status that I told you, sometimes they are hypo, sometimes they become hyperactive. Acute, all the changes are acute mental state changes. Inattention, very profound inattention. When you ask some question to a patient, they will not just listen to you, they are on their own, they are doing something, and it appears they do not listen to what you have said. Psychomotor disturbance, as I said, it could be hyper or hypo. It could be hyperactive or hyperactive. And acute disturbance in cognition. Cognition means higher mental function, like memory deficit, they do not remember sometime. Disorientation of person, place and time. If you ask where are you, they do not remember where are they. So all these things happen in a delirium state. The most important is inattention and disorganized thinking. If you see the level of consciousness or arousal state or alertness state in our human body is maintained by the ascending reticular activity system, ARS what we call, and the projection to the higher brain centers, especially thalamus and hypothalamus. So that is the arousal. This is how arousal is maintained by the ascending reticular activating system. Attention is like different. Like you are all are now attentive in the class, listening to what I am saying. So you are all are awake and attentive at the same time. Okay, but it may be possible patients are awake but not attentive, or inattention, or hyperattention, hypervigilant, what we call. Attention is again from the various other parts of, especially cortical input and input from neocortex into the again hypothalamus and into the input of ascending reticular activity system. So the various activities of the brain part form the arousal and attention. So we use various terminology for this issue in the ICU. We call it acute confusional state, what I have written just now. We call it delirium. We call it acute brain failure. You must have seen that, heard the term acute kidney injury, acute respiratory failure, acute renal failure. But this is a acute brain failure secondary to some other illness in the ICU. And also they use the term acute toxic metabolic encephalopathy. Toxic metabolic because there are various underlying toxins, various drugs, and there is metabolic cause which we'll discuss as we see, which can lead to this kind of issue. How common the delirium in the ICU is very fairly common. About 30%, 1% of patients on admission are delirious. 82% of patients requiring intubation and ventilation. Obviously, patients who require intubation and ventilation, they are more sick. It may be underlying respiratory failure or better in the cause maybe. So they are more sick. So chances of delirium are much more in the patient who require intubation and ventilation. Around 10 to 50% elderly surgical patient. It's more common in surgical patient, elderly surgical patient. As I said, hypoactive delirium is more common than hyperactive form. And the worst part about delirium is diagnosis is missed in about 60 to 80% of the cases. Intensivists or we do not like patients under delirium. Missed diagnosis basically I say always indicate they spent less time with the patient. Doctors, nurses, when do not spend adequate time with the patient, so you are likely to miss the diagnosis of delirium. So what is the basic pathology or why does delirium happen when the other organs are failing or the other acute illness, maybe acute infection like pneumonia or meningitis or any other infection could be, why the brain get affected, especially pneumonia. Brain functions basically various kind of neurotransmitters. So they somehow due to imbalance in the synthesis, relief, inactivation of neurotransmitters in the brain. The most common neurotransmitter in the brain is acetylcholine, which is the neurotransmitter of the ascending reticular activity system, as I said. ARS function on the base on the acetylcholine, which is how it maintains the arousal or awake state. So there is a decrease of acetylcholine because of critical illness. This is how it affects the arousal and attention. The increased activity dopamine. Dopamine is another important neurotransmitter in the brain. So increased activity dopamine and decreased activity acetylcholine, they are two important neurotransmitters. Other neurotransmitters are like serotonin. Serotonin is a very calming effect, cool effect on the mind. That is also GABA, gamma aminobutyric acid, it gets involved. Norepinephrine, patients of brain trauma have been found to have very increased activity of this norepinephrine in the brain who are very agitated. So this is about neurotransmitter theory, one theory which can result in the delirium. Second theory is about the inflammatory cytokines in the brain. Critical illness or any acute infection can cause increased cytokines in the brain, in the human body, in the circulation, especially interleukin 6, tumor necrosis factor, all the increased cytokines, they also affect the functioning of the brain leading to delirium. So what are the risk factors for developing delirium? As I said, a very good number of patients develop delirium after coming to the ICU. And many times we miss the diagnosis. Number one is acute illness. Patient having acute illness, risk for developing delirium. Any kind of acute illness. Second, patient-related factor. It's more common in patient advanced age, 70 years, more than 70 years. Why it is more common in patient advanced age? Sensory impairment. Patient having sensory beyond advanced age means patient may have various kinds of sensory impairment. Patient may have some hearing impairment, some vision impairment, and patient having underlying brain disease. As the age advances beyond 60, beyond 70, so with the age there is something called age-related cerebral degeneration or cerebral atrophy sets in, especially by the age of 70 years. There is the shrinkage of size of frontal lobe of the brain, and the hippocampus and frontal lobe, they are two main parts of the brain which start shrinking inside. And overall that's why there is arousal get affected and attention get affected, which puts this patient at very high risk of delirium. And there is environmental factor in the ICU. We do so much of invasive procedure, we do frequent taking sampling of the patient, we find difficult to sleep in the ICU. So which will do. So there are three main etiological factors in the patient who can push them into the delirium. The various kind of mnemonics, if you can you see this chart? Mnemonics for the risk factor for the agitation and delirium in the ICU. One is infection. I watched that. One mnemonic is that is any kind of infection, withdrawal from the drugs, any kind of drug, acute metabolic region, hyponatremia, hypocalcemia, trauma and pain, central nervous system pathology, meningitis, encephalitis, hypoxia, deficiency of vitamin B12 and thiamine, again much more common in patients having alcoholism, endocrinopathies, acute vascular hypertension, toxins and drugs, and heavy metals. Second, again mnemonic, delirium per se, very drugs as I said, electrolytes and physiological abnormalities, lack of drugs, drugs withdrawal, patient has been used to taking some drug, infection, reduced sensory input that include blindness, deafness, intracranial problem, patient having urinary retention and fecal impaction. Very common cause. Patient not able to pass urine because of urine retention can push them to delirium and then myocardial problem. Third thing, another day, again one more mnemonic thing, a toxic situation, CHF, shock, organ failure, hypoxemia, hypercarbia, infection, inflammation, immobility, then non-pharmacological intervention, and potassium or other electrolyte abnormality. So these are some of the mnemonics explaining the risk factor for the delirium and agitation in the ICU. Other than this, there are some precipitating factors. Again, I said drugs and polypharmacy. We use large number of drugs in the OT and ICU, especially opioids, benzodiazepines, steroids. All the drugs can push the patient to delirium. Various infections, metabolic derangements, metabolic acidosis, hyponatremia, hypocalcemia, hypercalcemia, they all metabolic derangements can cause delirium. Underlying brain disorders, patient having underlying CBA or any other kind of brain disorders, they are more prone to develop delirium. Organ failure, acute kidney injury or acute renal failure, patient coming with the same treatment more than 2, they can push them to delirium. Acute liver failure, patient coming with high bilirubin levels, again can present with a delirium. Many times you find the first presentation of underlying systemic illness may be just delirium in the ICU. Patient come to you in a very agitated state or very acute confusional state, not listening. You don't know what is the diagnosis. When the patient comes initially, no work has been done. You don't know what is the underlying cause. Then slowly you realize it's underlying maybe the metabolic acidosis or acute renal failure or acute liver failure. Acute liver failure is a very common cause and patient presented with the delirium to the ICU. Passing urinary catheters, very uncomfortable for the patient. Nasogastric tube, putting central venous catheter, all these things can precipitate the delirium in the patient. Restraints, we commonly use either hand restraints, handcuff, and do not allow the patient to move. And I have seen more the restraint we put, patient become more delirious. Like the other way of putting restraint, this is done by our staff in the ICU. They try like the patient move very restless, trying to get up from the bed even after tying both the hands. They put this kind of restraint on the patient, and more restraint you put, patient become more delirious. Many times I just tell the patient remove the restraints, and the moment you remove the restraint, patient become very comfortable and delirium just goes away. I do not say delirium restraints are not required in the ICU. At times they are required when the patient, you have tried everything and it's not working and you want the patient to be safe. Do not pull out the endotracheal tube or do not pull out very lines. So at times restraints are required, but I feel it is too overused in our ICU. Not only restraints, giving too much of endless sedation. Again, I have seen many times the patient just nursing staff just give even muscle relaxant, atracurium. Why you give natriureum? Patient was trying to bite the tube, trying to take out the tube. So simple thing is to give the atracurium or increase sedation. So whenever patient is restless, delirious, confused, it is very important to find out the underlying cause for the delirium. Patient will be hypoxic, there is more secretion in the airway, more secretion in the trachea, there will be underlying metabolic acidosis, there will be increased lactate in the body, or there will be some underlying electrolyte disturbances which is called delirium. So try to treat the underlying cause for the delirium and not just giving more sedation, more fentanyl, more midazolam, and even at times atracurium people give just to so that patient doesn't look delirious. How do you evaluate the patient delirium? You have to recognize the underlying disorder. What is the underlying cause for the delirium? As I said, there is always some underlying medical cause. There could be n number of causes which can lead to almost any medical illness, any surgical illness can lead to delirium. Take a proper history of the patient, do physical examination, and then medication review. What all medication patient has been taking, or is there any recent change in the medication? You just add steroid, say maybe hydrocortisone or dexamethasone or even methylprednisolone. Even 1 or 2 doses of steroid can push the patient to delirium. Search for underlying cause, basic lab tests you can do, CBC, hemogram, ABG, liver function, renal function, and try to look for the underlying. Society of Critical Medicine recommends routine monitoring of the pain, anxiety, and delirium in the ICU. That they call PATIS guideline. What is PATIS guideline? Anybody can tell me what is PATIS guideline? Pain, agitation, delirium. What is I? Immobility. And what is S? Immobility, and I think S is early mobility, and just leave what is S. So this is guideline given by the Society of Critical Medicine. They say that pain, a very common cause of patient on ventilator. You just put a arterial line sometime, and sometimes they do give local, sometimes people do not give local. So putting a simple arterial line is a very much painful procedure, one of very severe painful procedure, putting this arterial line. Removal of a chest tube, very painful. And generally we do not give any analgesic or medication for this before this. And this kind of transient painful experience. Moving patient on the bed, positioning, repositioning, itself very painful. Patient having surgical pain or post-op pain or multiple chest injury, we reposition the patient, move the patient. All these movements are very, very painful. So you have to think about the pain, we have to think about the agitation, and actively manage by giving various drugs and pain relief. Another diagnostic tool, but I know that you heard of this CAM ICU, Confusion Assessment Method. CAM, this was initially devised for the assessment of confusion and delirium in the ward. Later on it was modified for the ICU, and it was found to be very, very useful diagnostic tool. It gives you objective criteria for you to assess whether patients have delirium or not. Devised by one of the Dr. Sharon K. She works for the Center of Aging Brains in the California, in the San Francisco, and she devised this scale, CAM ICU, and they say it should be used on all the patients on daily basis. You just take about 2 to 3 minutes to administer this CAM ICU and this scale and tell you patient is in delirium or not. It has been validated and commonly used for the development or resolution of delirium. This tool has got 4 features, CAM ICU. One is acute onset of mental illness, change or fluctuating course. Second, you have to ask certain question and to look for the inattention of the patient. Inattention, how do you know? You just say one word, other patient repeats some word, like you say heart, and you tell the patient, when I say heart, when the A comes, you press my finger. Then you come to know whether the patient is having attention or not, whatever you are asking. Disorganized thinking. How do you know patient or thinking disorganized or not? You ask simple question to the patient, do you think if I just throw this stone into the water, this stone will float or not? Then patient says, yes, it will float. Stone will float in the water. So this is disorganized thinking. Altered level of consciousness one can make out by looking at the RAS scale. What is RAS scale? Richmond Agitation Scale, okay, analgesic scale. So by looking at the RAS scale, one can make out the altered level of consciousness. So this CAM ICU has been found to be an excellent tool for screening and diagnosis. Another tool for the screening purpose is the ICDSC, Intensive Care Delirium Screening Checklist. Is another tool which has been used in the ICU by the intensivist. So you can use any of the CAM ICU is found to be a little more sensitive and specific than the ICDSC tool. In ICDSC there are about 8 points. If you can see, altered level of consciousness, inattention, disorientation, hallucination, delusion, psychosis, psychomotor agitation or retardation, inappropriate speech or mood, sleep-wake cycle disturbances, and symptom fluctuation. Total score is from 0 to 8. You just give 0 point or 1 point. If any of thing is present, you just say 1. If it is absent, just give 0. So plus present or not present. Disorientation, hallucination, psychomotor agitation. So, and then how do you? So one of the 2 studies I have found this article published in about 2012, and the confusion assessment and the ICDSC score for the diagnostic delirium and they found to be very useful and highly sensitive and specific. If you see this, and they classify as per the CAM ICU. If it is 0 CAM ICU score, no delirium. If they 1 to 2, there is subsyndromal, very likely minimal possibility of delirium. Find 3 to 5, mild to moderate delirium. And if it is 6 to 7, it is severe delirium. 6 to 7 means severe delirium. Same ICDSC, 0 means none, no delirium. 1 to 3, subsyndromal, and 4 to 8 means severe delirium. Again, this was one of the study published in 2020. So these two scales, CAM ICU and ICDSC, can be used for the assessment of delirium. What is the prognostic significance of delirium? Why we are so much worried about the delirium? Delirium can prolong the stay of the patient in the ICU, can prolong the mechanical ventilation, can delay the discharge, can cause more chance of aspiration. It can lead to nosocomial pneumonia. The patient pulls out the endotracheal tube. It can lead to nosocomial pneumonia, aspiration, self-extubation, pulling out the central lines, IV lines, urinary catheters, NG tubes and drains. Patient can get more injuries, injury to the airway, more bleeding to the urinary tract. All these things can happen and the patient remains delirious and agitated. They can fall from the bed, get more injured, increase hospital stay and mortality, and increase cost to the hospital and to the patient, 31% more cost. And also, when the patient develop delirium in the ICU, there is possible long-term cognitive impairment and dementia. Even after 2 to 3 years, they have been found their higher mental function, especially cognitive function, remain impaired even after 2 years of discharge from the ICU. So that's why we must take precautions to prevent and treat delirium. Prevention is more important. I said that prevention is very important. The delirium, we should have orientation protocol. You can put up clocks in the ICU calendars so that the patient know what is the time of the day, what is the date and time. You can have some kind of cognitive stimulation, repetitive orientation, family involvement. Like recently I have been to Mayo Clinic in USA, Arizona, and their ICU I found every ICU next to the patient bed there is a big couch. I said, what is the couch for? They said it's for the attendant to sit there. So every ICU patient, they allow attendant to sit next to the patient so that they do not face the problem of delirium in the ICU or disorientation. So because their family member can talk to them, can provide constant cognitive stimuli, which we can't do as a healthcare provider. Allow the normal physiological sleep, develop sleep protocol. There should be minimal disturbance to the normal sleep. Early mobilization, minimal use of restraints. Patient should be mobilized from the bed, out of the bed as early possible. Timely remove all the catheters, remove urinary catheter, remove NG catheters, central venous catheter whenever they are not required. Replace eyeglasses and hearing aids. Schedule pain management protocol. Reduce the use of anesthetic drug. Patient coming as a post-op patient. So in the OT, anesthetic should make an effort to reduce the minimal use of anesthetic agent like propofol, opioids like fentanyl, and they can use with a BIS. If they use the bispectral drugs, this will cut down the use of anesthetic agent and reduce the post-op delirium. TADA approach, tolerate, anticipate and don't agitate. By this various protocol, about 30 to 40% of all TCA delirium could be prevented. It's a huge achievement. So 1 in 3 cases of delirium are preventable, spotted, treated and prevented. Treatment is more difficult, as prevention is more easy. Treatment is the identifying treatment underlying cause. You have to find out why there is a delirium patient found to delirious. Is it metabolic acidosis or is it hyponatremia? If it develops in a previously normal patient, then search for the possible cause. Patient has come to the ICU maybe with a delirium or after coming to the ICU, after maybe few days or after few hours, patient become delirious. Like the patient I showed you, after 24 hours of admission to the ICU become delirious. So previously she was normal, but what has gone wrong within 24 hours which has led to delirium? To look for a possible underlying cause. What is the drug therapy? Can we give some drug for the delirium? Yes, we can give drugs like haloperidol is one drug commonly used. It's a butyrophone neuroleptic drug and it is a dopamine receptor antagonist. As I said, one of the reasons for delirium is increased dopamine activity. So haloperidol, a drug which reduces dopamine activity and controls the delirium. Dopamine can be given as a IV generally given IV small dose 1 to 2 milligram and can be given up to maximum up to 10 gram. Give 1 milligram or 2 milligram haloperidol. Wait for about 10 to 15 minutes. If find patient still not safe, give another double the dose of haloperidol. Haloperidol can be combined with lorazepam. If you combine haloperidol with the lorazepam, it has got more additive effect. So what is side effect of haloperidol? It can cause sometimes, very rarely described, it can cause the prolonged QT interval. So always look for the QTC and control with the ECG, and the QTC more than 530, do not give haloperidol. Newer atypical antipsychotics nowadays available, they call second line antipsychotics like quetiapine, olanzapine, risperidone, and they have lesser side effect. They do not got prolonged QT interval. So after initially giving haloperidol of 1 to 2 milligram, one can switch over. At the same time, start oral antipsychotic drug like quetiapine. We commonly start the quetiapine 25 milligram thrice a day, and within 24 to 48 hours, patient will become quiet. Cholinergic agents like cholinesterase inhibitor, neostigmine, physostigmine, they are not very useful. Dextrometamine, another drug, if you use for the ICU sedation, there is reduced incidence of delirium in the ICU. ABCDEF bundle is also advised for delirium treatment. A basically means it's a bundle care for delirium. Assess, prevent and manage pain always. B, give both spontaneous awakening and breathing trials. C, choice of appropriate sedation. Use dexmedetomidine in spite of using midazolam, which can cause very high incidence delirium. Use dexmedetomidine. So avoid midazolam, avoid fentanyl, use dexmedetomidine. Delirium monitoring and management. Early mobility and exercise. Try to mobilize the patient as early as possible. And F, family engagement and empowerment. So ABCDEF bundle for the delirium management. Now this patient is quiet after 24 hours when we start the treatment. Differential diagnosis, one can easily make out the sundowning happen in a patient of either Alzheimer's or dementia. By the evening they are a little tired, exhausting, they are called sundowning. Focal syndrome, especially the focal epilepsy syndrome. NCSC, non-convulsive states of epilepticus, they can be confused with delirium. Patient with dementia is more of a chronic problem, delirium is not. And primary psychiatric illnesses, but patient coming with any kind of psychiatric illness, then develop delirium, most of the time you can make out whether it's a delirium or underlying pre-existing psychiatric illness. To conclude, I will say that delirium agitation in the ICU jeopardizes the safety of the patient and staff at times. They can get up and they start hitting the patient staff also. And there is underlying always pathology causing acute illness. And you prevent delirium by judicious use of drugs and devices. You will use both pharmacological and measures, what I told, like ABCDEF protocol. And the manipulation of two axes in the brain, that is dopaminergic axis and cholinergic axis, is the basic treatment for the pharmacology for the control delirium. Any question you want to ask? This is what MCQs I was told. ICU psychosis, just answer to this MCQ. ICU psychosis is a misnomer. Answer is misnomer. One should not call it ICU psychosis. It is a delirium. Okay. What is the answer to this question? Drug of choice to treat acute delirious patient in the ICU is haloperidol. Very correct. What is this? All of the following measures can be used to reduce incidence of delirium in a post-operative patient except? Yes, answer is A. Do not use atropine for the pre-medication, or you can use BIS, you can use intra-post in control and use dexmed for the post-op. Answer to this, preferred drugs for ICU sedation to reduce emergence of new delirium. Perfect. So you understood what I said.